Hello, my name is Dr. Tina Abraham, and I am a practicing allergist immunologist located in Rochester Hills, Michigan. Thank you for watching. It is my pleasure to share with you Asthma and AIRSUPRA, 10 things to know. In this video, I'm going to cover some information about asthma and asthma rescue before discussing important information about AIRSUPRA, albuterol budesonide inhalation aerosol. Please see important safety information throughout and see the full prescribing information, including patient information, by pausing this video and scanning the QR code on your screen or by visiting airsuprahcp.com. Let's get started. Number 1. The approach to asthma rescue has shifted over time. You may be asking yourself, why are we talking about asthma rescue? Over the last few years, there have been substantial changes to asthma expert recommendations that give healthcare professionals guidance on how to manage asthma. In terms of asthma rescue, both the National Asthma Education and Prevention Program, NAEPP, and the Global Initiative for Asthma, GINA, include recommendations for treating symptoms and inflammation with a rescue approach, keeping in mind that the GINA report no longer recommends SABA-only treatment of asthma. This recommendation is largely due to risks associated with the use of SABA alone versus an asthma treatment plan that includes an ICS. Now, we're going to talk about the rationale for why these recommendations are important. Number 2, both bronchoconstriction and inflammation contribute to asthma symptoms. While SABA rescue treats bronchoconstriction, it does not address inflammation, which contributes to asthma symptoms such as cough, chest tightness, shortness of breath, and wheezing. As we have come to understand, breakthrough symptoms are driven by both bronchoconstriction and unpredictable rises in inflammation. As shown in this illustration, inflammation and symptoms vary over time and in intensity. Maintenance therapy is intended to address baseline inflammation, as shown by the dashed line in the illustration that is characteristic of asthma. However, inflammation is variable, and rising inflammation can result in breakthrough symptoms. SABA alone doesn't address inflammation, leaving patients at risk of increasing symptoms and an exacerbation. With this background in place, I would now like to transition away from the disease state portion of this video and introduce you to AIRSUPRA, albuterol budesonide inhalation aerosol, a superpower in asthma rescue. Number 3. What is AIRSUPRA? AIRSUPRA is a combination of albuterol, a beta-2 adrenergic agonist, and budesonide, a corticosteroid indicated for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma, 18 years of age and older. AIRSUPRA is contraindicated in patients with a known hypersensitivity to albuterol, budesonide, or to any of its excipients. Patients should be monitored for asthma deterioration. If the patient continues to experience symptoms after using AIRSUPRA or requires more doses of AIRSUPRA than usual, this may be a marker of deterioration of asthma and requires a re-evaluation of the patient. Stay tuned for additional important safety information. Scan the QR code or visit airsuprahcp.com for full prescribing information, including patient information. AIRSUPRA is the first and only anti-inflammatory rescue treatment containing both a SABA and an ICS that is FDA approved for as-needed use. When patients experience asthma symptoms, it is recommended to take 2 inhalations of AIRSUPRA, albuterol 90 micrograms, budesonide 80 micrograms, as needed, with no more than 12 inhalations of AIRSUPRA in a 24-hour period. AIRSUPRA is a rescue medication. It is not to be used as a maintenance medication or to replace daily maintenance therapy. Number 4, AIRSUPRA pivotal trials, Denali and Mandala. Next, we would like to share a brief overview of the Denali and Mandala studies. AIRSUPRA was studied in approximately 4,000 patients across all asthma severities, including mild, moderate, and severe, just like the patients you may see in your practice. Denali was a lung function study in patients with mild to moderate asthma. Mandala was an exacerbation study in patients with moderate to severe asthma. The safety populations for Denali and Mandala included patients greater than or equal to 12 years old. However, while patients 12 to 17 years were included in Denali and Mandala, AIRSUPRA is not approved in this age group. Efficacy results will only be presented for adults greater than or equal to 18 years of age. Number 5, the Denali study design. Denali was a phase 3 randomized, double-blind, multi-center, active comparator and placebo-controlled lung function study conducted over 12 weeks in 989 patients at least 12 years old with mild to moderate asthma. The study evaluated the efficacy and safety of AIRSUPRA versus albuterol, budesonide, and placebo. AIRSUPRA is a rescue therapy and is not indicated or approved for maintenance use. While patients 12 to 17 years were included in Denali, AIRSUPRA is not approved in this age group. Therefore, efficacy results are presented only for the approved population of adults greater than or equal to 18 years of age. Since albuterol budesonide 180/80 micrograms is not an approved dose, this presentation will not include results for this arm of the study. To participate in Denali, patients needed to be previously treated with as-needed SABA only or stable low-dose ICS in addition to as-needed SABA. In addition, patients had a pre-bronchodilator FEV1 of greater than or equal to 50% to less than 85% of predicted normal and demonstrated reversibility. Patients enrolled in Denali were predominantly female and Caucasian. Mean pre-bronchodilator percent predicted FEV1 was 65%, with a mean reversibility of 29%. 48% of patients were on pre-study ICS background therapy, while 52% were not on ICS containing therapy. Number 6, Denali key results. In Denali, the onset of bronchodilation with AIRSUPRA was as fast as albuterol. Among patients who achieved a greater than or equal to 15% increase in FEV1 post-dose within 30 minutes on day 1, the median time to onset of bronchodilation with AIRSUPRA was 7.5 minutes versus 10 minutes in patients receiving albuterol. Note that the data were not evaluated for statistical significance. Results are descriptive only. In Denali, the following adverse reactions for AIRSUPRA occurred with an incidence greater than or equal to 1%. Headache, 5.1%, dysphonia, 2%, and oral/oropharyngeal candidiasis, 1.5%, compared to headache, 7.1%, dysphonia, 0%, and oral/oropharyngeal candidiasis, 0% in the placebo arm. Data shown are for patients greater than or equal to 12 years old. AIRSUPRA is not approved for patients 12 to 17 years of age. Number 7, Mandala study design. Mandala was a phase 3, randomized, double-blind, multi-center, variable-length exacerbation study of at least 24 weeks duration that evaluated the efficacy and safety of as-needed AIRSUPRA compared with as-needed albuterol. The study enrolled 3,040 patients aged 12 years and older with symptomatic moderate to severe asthma who were receiving daily ICS-containing maintenance therapy. The primary efficacy endpoint was the time to first severe asthma exacerbation. Key secondary endpoints included annualized severe exacerbation rate and annualized total systemic corticosteroid dose. While patients 12 to 17 years were included in Mandala, AIRSUPRA is not approved in this age group. Therefore, efficacy results are only presented for adults greater than or equal to 18 years of age. To participate in Mandala, patients had to have one or more severe asthma exacerbations in the previous year. In addition, patients must have been on asthma maintenance therapy for at least 3 months with stable dosing for 4 or more weeks prior to screening. Lastly, patients must have a pre-bronchodilator FEV1 between 40% and less than 90% of predicted normal with confirmed reversibility to albuterol. Patients enrolled in Mandala were predominantly female and Caucasian. Mean pre-bronchodilator percent predicted FEV1 was 63%, with a mean reversibility of 28%. 80% of patients had one severe exacerbation the prior year, with 20% of patients having more than one. Additionally, all patients continued their ICS-containing maintenance therapy throughout the trial. In Mandala, patients were instructed to use AIRSUPRA or albuterol as they would normally use their rescue medication. Number 8. Mandala results, primary and key secondary endpoints. In Mandala, AIRSUPRA demonstrated a superior 28% reduction in exacerbation risk versus albuterol as measured by time to first severe exacerbation. Reductions in exacerbation risk with AIRSUPRA were observed regardless of the patient's background maintenance therapy, exacerbation history, or baseline lung function. A key secondary endpoint in Mandala was the annualized total SCS dose. There was a superior difference in the annualized total SCS dose with AIRSUPRA compared with albuterol, with a 32% reduction in mean annualized SCS dose per patient. Number 9. Mandala Adverse Reaction Profile. In Mandala, AIRSUPRA demonstrated a safety profile similar to albuterol regardless of background ICS dose. Adverse reactions reported in greater than or equal to 1% of patients who used AIRSUPRA included headache 4.3%, oral candidiasis 1.3%, and cough 1%, compared with headache 4.9%, oral candidiasis 0.5%, and cough 1.1% in the albuterol arm. Data shown are for patients greater than or equal to 12 years old. AIRSUPRA is not approved for patients 12 to 17 years of age. Number 10. We will now review additional important safety information for AIRSUPRA. AIRSUPRA can produce life-threatening paradoxical bronchospasm or clinically significant cardiovascular effects. Discontinue as needed. AIRSUPRA, like other drugs containing beta-2 adrenergic agonists, can produce clinically significant cardiovascular effects in some patients as measured by heart rate, blood pressure, and/or other symptoms. If such effects occur, AIRSUPRA may need to be discontinued. Also, beta agonists can produce ECG changes, such as flattening of the T wave, prolongation of the QTc interval, and ST segment depression. Therefore, AIRSUPRA, like all sympathomimetic amines, should be used in caution with patients with cardiovascular disorders, especially coronary insufficiency, cardiac arrhythmias, and hypertension. Patients should not exceed the recommended dose. Clinically significant cardiovascular effects and fatalities have been reported in association with excessive use of inhaled sympathomimetic drugs. Hypersensitivity reactions, including anaphylaxis, can occur after administration of albuterol and budesonide, which are components of AIRSUPRA, as demonstrated by cases of anaphylaxis, angioedema, bronchospasm, oropharyngeal edema, rash, and urticaria. If this were to occur, discontinue AIRSUPRA. AIRSUPRA, like all therapies containing sympathomimetic amines, should be used in caution in patients with convulsive disorders, hyperthyroidism, or diabetes, and in patients who are unusually responsive to sympathomimetic amines. Beta-adrenergic agonist medicines may produce significant hypokalemia in some patients. The decrease in serum potassium is usually transient, not requiring supplementation. Due to possible immunosuppression from the use of inhaled corticosteroids, ICS, potential worsening of infections could occur. Use with caution. A more serious or fatal course of chickenpox or measles can occur in susceptible patients. Oropharyngeal candidiasis has occurred in patients treated with ICS agents. Monitor patients periodically. Advise patients to rinse their mouth with water, if available, without swallowing after inhalation. Hypercorticism and adrenal suppression may occur with very high doses in susceptible individuals. If such changes occur, consider appropriate therapy. Decreases in bone mineral density have been observed with long-term administration of ICS. For patients at high risk for decreased bone mineral density, assess initially and periodically thereafter. Glaucoma and cataracts have been reported following the long-term administration of ICS, including budesonide, a component of AIRSUPRA. Orally inhaled corticosteroids, including budesonide, may cause a reduction in growth velocity when administered to pediatric patients. As we have previously mentioned, the safety and effectiveness of AIRSUPRA have not been established in pediatric patients, and AIRSUPRA is not indicated for use in this population. The most common adverse reactions with incidence greater than or equal to 1% are headache, oral candidiasis, cough, and dysphonia. For drug interactions, AIRSUPRA should be administered with caution to patients being treated with strong cytochrome P450-3A4 inhibitors, short-acting bronchodilators, beta blockers, diuretics or non-potassium-sparing diuretics, digoxin, monoamine oxidase inhibitors MAOI, or tricyclic antidepressants. Use AIRSUPRA with caution in patients with hepatic impairment, as budesonide systemic exposure may increase. Monitor patients with hepatic disease. We have just covered asthma and AIRSUPRA, 10 things to know. I hope this information is helpful. Thank you for watching. To learn more about AIRSUPRA, scan the QR code or visit airsuprahcp.com for full prescribing information, including patient information. References used throughout this video are shown here.